Welcome to Diagnostic Imaging. I'm Senior Editor Whitney Palmer. We're back with you this holiday week to bring you some of the highlights of radiology news. This week saw a flurry of developments with MRI. In a study published in the journal Radiology, researchers from Germany used 3T MRI scanners to image and measure iron levels in the neocortex, the heavily grooved outer layer of the brain that is integral to language, conscious thought, and other functions. Historically, the neocortex has been difficult to image because its anatomy prompts distortions, signal decay, and artifacts in MRI scans. However, in this study, investigators were able to show, by comparing patients with Alzheimer's to healthy participants, that iron levels were higher in the whole cortex for patients with Alzheimer's, revealing the association between high iron levels in the brain and cognitive deterioration independent of the loss of brain volume. Additionally, the researchers said, their findings point to the possibility of using chelators, iron-reducing drugs, as a potential therapy for Alzheimer's. A second study, published this week in Cancer Research, detailed how an existing MRI technique called T1 mapping could potentially be used to determine whether children have a particularly aggressive type of cancer, neuroblastoma, and whether the treatment is working at an earlier stage. Though their current research was conducted in mice, investigators from the Institute of Cancer Research in London said their findings could be applied clinically. In the study, the team used T1 mapping MRI scans to map different tumor cell populations and compared them to maps created with artificial intelligence. They discovered maps with high T1 values corresponded to areas with more aggressive cancer cells, and lower T1 value spots were more benign. They also used T1 mapping to determine the efficacy of two neuroblastoma targeting drugs, alisertib and vistusertib. And they found that when the drug succeeded, T1 measures dropped. Their hope, they said, is that this technique can be used to both improve treatment for aggressive cancer and limit the medication side effects children experience by minimizing their exposure to drugs that might not be working. And in a third study, published in NeuroImage, a team from the University of Maryland, Baltimore County detailed a new image analysis method called independent vector analysis for common subspace extraction that can be used to categorize fMRI data based solely on brain activity. Clinically, it can help providers treating patients with schizophrenia by grouping them based on their brain imaging alone. Treatment for schizophrenia is not a one-size-fits-all endeavor. So this data, they said, can be used to judge whether a treatment is working, potentially leading to a change in therapy if a patient is seeing no improvement. The investigative team has a plan to research this method's efficacy with addiction and substance abuse in adolescents as well. And finally, across the country, academic medical centers and community hospitals are beginning to see a steep spike in their numbers of COVID-19 patients. Consequently, triaging and managing these patients has become an ever more critical task as resources and personnel begin to stretch thin. One institution in this position is the University of Texas Health in San Antonio. Within the past 2 weeks, the health system has seen a quadruple increase each in their numbers of diagnosed COVID-19 cases, the number of patients hospitalized, and the number of patients on ventilators. Diagnostic Imaging spoke with Dr. Nilam Soni, director of the point-of-care ultrasound training program in the South Texas Veterans Healthcare System associated with the University of Texas Health, about the role the bedside modality is increasingly playing and how they are handling this growing patient volume. Here's what he shared.
What happened with COVID-19, back in end of January, beginning of February, I was getting messages from my colleagues in Spain, Italy, and it was really bad there. And everybody here was just kind of, really oblivious and like, oh yeah, life is good. And we were like, oh my God, this is going to be really bad when it comes here. And so we started talking about how are they using ultrasound and what are the benefits of ultrasound? And so a couple of important points. First, because we had to put these patients into isolation, it's very hard to get diagnostic imaging on them. So to go get a CAT scan, you got to cover them up. If you look online, like in Italy, they had these like plastic tubes to transport the patients. It was almost like a plastic cylinder to cover them up. So then you take that patient, we don't have those here, I haven't seen them here, but you take that patient like that with a mask, obviously, and everything sort of covered up so they're hopefully not spewing out virus down to the radiology suite, and they shouldn't have a waiting time. Typically there's a holding area, but you can't put these patients in a holding area. Then you put them on a CT scanner, and you take them off the CT scanner, transport them back up through the elevators, down through the hallways, through the elevator, up to the ICU, wherever that may be, and then back to their bed. So they're exposing all these areas which need to now be decontaminated, right? So then you had to take these, toxic wipes like this, which are expensive. Now they're running out of stock and they're hard to get. They're toxic, obviously carcinogenic. Put some gloves on and then clean all this equipment like the CT scanner, which can take an hour or two to do. You have to do it properly. If you don't do it properly, well, somebody else who comes in could now get infected unless you keep one CT scanner for that all COVID patients. But a lot of places may be only fortunate to have one scanner for everybody. Like most of America is rural, 95, 99%, depending upon how you define it, is going to be rural. So at any rate, with ultrasound, we can get to the bedside. If you have trained providers and you have access to equipment, you can, in many cases, get your answers right there at the bedside. So if the question is, are their lungs looking worse? Well, if you had an ultrasound that showed when the patient first came in and they looked bad, but now they look a lot worse, well, now we know they are getting worse. The oxygenation is looking worse. All the numbers are looking worse. Do we really need to get additional imaging? Besides CAT scans, we have x-rays. But again, x-rays require a technician to come in the room, roll in a machine if you're going to do a portable, and now that machine needs to be decontaminated. If you take them down to radiology to get a formal x-ray down in the radiology suite, again, you got to transport them, got to have a transporter, you got to decontaminate all the equipment again. So if you can do all this right there at the bedside, there's lots of advantages. It's quicker, it's in real time, you can make decisions right there with the patient. And then you can avoid all these other imaging tests. We still need CAT scans. We still sometimes need x-rays, but all the literature has shown point of care lung ultrasound for a lot of common indications is similar to CT scans in diagnostic accuracy, and definitely better than x-rays. So even we just submitted a paper for publication from COVID-19 patients. And in how many, I'm trying to remember what the number was now. In the patients who had a normal chest x-ray, about half of them had abnormalities that we found on ultrasound. And these are COVID-19 patients. So this is a radiologist reading the x-ray too. This is official x-ray read by the radiologist. The report says normal. When we do the ultrasound, we find there actually are abnormalities. So, if we can get the answer at the bedside using ultrasound, then we can reduce resource utilization. So less staff time, less equipment usage, less sanitizing wipes and things that are being used to clean the machines. We can get the answers quicker because we're right there at the bedside. Now we can move to the next step, which is making a decision on what we want to do. We can also do more, patient-centered care. We can incorporate the patient into the decision-making, right? Patients like it when doctors are at their bedside. That goes for COVID with or without COVID. But when you're there at the bedside, patients like that you spent more time with them, and patients like to see their images, right? It changes the conversation in many ways. And they say, oh, wow, that's what's going on. And I'll tell you, a lot of our veterans are not, they don't have a lot of high level education and health literacy in medicine, but they can read their images. They can tell you, oh, wow, there's a lot more fluid in my belly, or that looks a lot worse than it did last time, doesn't it? And you're like, yeah. If we see this in the outpatient setting with our paracentesis clinic where patients have cirrhosis and they have ascites, they can tell you that they've got more fluid in their belly by looking at the image. Well, it changes the conversation. They understand also their body's better. Just says 1,000 words, right? The old saying. So you show them, and then that changes the conversation. They say, oh, wow, there's a lot more fluid. So why did I get more fluid? Well, let's talk about that. Why did you get a lot more fluid? Are you following your diet? Are you taking your medicines? And for certain people, I think it triggers that special spot in their brain that you need to trigger to make them change their behavior. But for COVID-19, I think, the big benefits are saves us resources, saves us the time and staff effort for decontaminating radiology equipment. It gives us immediate information at the bedside. And I think for triaging patients, it can also be very helpful on the outpatient or the emergency room perspective.
All right. Well, then, given that there are all these benefits that are presented, particularly with COVID-19, and the fact that your facility and countless others across the country are now seeing part of, I guess we can call it the second wave or a surge of the first, whichever people decide to this is. How impactful is it to have point of care ultrasound? What is the actual impact that having that modality is making now that you're seeing this uptick in patients?
Yeah. So what we did here at our VA, which was really, I don't want to say cutting edge, but it was very forward thinking. We created a closed COVID unit. So the other colleagues I have here, they also have friends in Italy and Germany and other places. And they were like, oh my God. So we were all sweating bullets at the beginning of March, end of February, or middle of February to the beginning of March. And we created a closed COVID unit. So we have everybody gowned with, these maxillary suits. And so the PPE concern in some ways goes away because you're not having to go through masks all day. So we created this closed COVID unit, and then we said, how are we going to monitor these patients? Because getting x-rays on every patient every day, it's just not going to even be feasible. And, we're trying to move away from that in the ICU setting. Well, why don't we use ultrasound? So, at the time, the best I could do was I came up with this protocol, which we've shared. The American College of Chest Physicians use kind of put their recommendations out there too. But this was sort of the scanning protocol that we came up with for the upper lobes, middle lobes, and lower lobes. And then also here's sort of the codification schema we have for different findings. So we can put everybody into a category. So now we just number them. Okay, upper lobe gets a 1, middle lobe gets a 2, right lower lobe here, we give it a 2, we give this one a 3, we give this one a 4, so we number, and then we do one quick view of the heart. And then we can mark this window or wall. And so this is kind of a sheet that stays in the room. And then we can kind of do our weekly, this is like our code, you follow this every day. So I think the big impact though of doing this, so what I would just say is, in some ways we're unique. We really took a departure from the traditional approach and said, let's rely on this ultrasound. We're still going to need to get x-rays every now and then or CAT scans, but let's use ultrasound on everybody. And I think the biggest impacts have been, we've been able to reduce getting x-rays on patients. We've been able to reduce having to get CAT scans on patients. Not completely eliminate. We still had to get them sometimes, but we've been able to reduce it significantly. We've been able to make more informed decisions at the bedside, right? So you may initially, the patient says, I feel okay, but you start looking at the lungs and they look a lot worse than prior. It's like, you start thinking, well, maybe this patient's getting worse. And then over the next 6, 12, 24 hours, they declare themselves and they actually are getting worse. They're requiring more oxygen. They say they feel worse. Maybe they're needing to get intubated. So I think early detection of deterioration is another one, so that you could be more proactive. If they're getting better, it's all great. But if they're not, they're getting worse, at least it's an alarm to say, we need to watch this person closer. Another thing we've learned is that the lungs don't normalize for several weeks. So we sent patients home and their lungs still look pretty abnormal, although they're feeling better. So it takes a while for people to recover. I think the biggest impacts are reducing the number of x-rays we had to get, reducing the number of CAT scans we have to get, which some of the downstream effects are less radiologist burden, less staff burden for scanning them, less technician burden for putting them on a CT scanner, the transport that has to take them downstairs, et cetera. And we've been able to, maybe also just save sort of decontamination of resources like the wipes and all that sort of stuff, which, there's a shortage of all that stuff. So it's a big deal.
Absolutely. Well,
I think I would say, maybe the last thing I would say is like the patients, we haven't captured any data around this, but the patients definitely like it, right? They like that you're there and you're spending time with them versus, whizzing in and whizzing out of the room. Now, we still try to, if they're spewing out a lot of virus in the room, we still try to minimize our time in the room to reduce our risk. Having said that, knock on wood, we haven't had anybody get exposed because within the hospital or within our COVID unit.
Great. Well, given that you have been using point of care ultrasound so extensively, for I guess the remainder of this pandemic, and then maybe for coming out of it once we get to this other side, what are some lessons learned that you have gleaned from this experience in how to use point of care ultrasound maybe a little more efficiently or extensively, or just what we can expect from the modality itself?
Yeah. And going back real quick to the impacts, I'll tell you this early on. See, we had a small surge, a small bump in April and May. And at that time, our radiologist, so the people that would be against using point of care ultrasound would be imaging specialists historically. The battles are less and less, but radiologists who don't really understand how it's being used could be naysayers, cardiologists also. But I'll say, those are our colleagues, right? Once they understand how we're using it and they appreciate it, it actually helps them. And then they realize, oh, wow, this actually have a benefit to us. So then they become proponents. I'll tell you that early on, our radiologists were questioning its utility and saying, oh, there's no literature around this. And we were saying, well, there's no literature because this disease was just described a couple months ago, and you're not going to get the literature until, 6 months, a year or two down the road. Those same radiologists sent an email about a week ago saying, our CT scanners are overwhelmed. It's taking 2 hours to clean them. You guys are ordering way too many CAT scans. And so it's kind of funny because we go back, and so I dig up the conversation from, 6 weeks ago and said, or 2 months now, I had to say ago, and said, well, that's why we said we need to be using the lung ultrasound routinely, because that's the experience people had in other countries that we can learn from without having to experience it ourselves. And we knew that this was going to happen once we get a surge of patients. So at any rate, what do I see? How do I think it's going to change the world afterwards? I think it highlights the gaps we have. The big gaps we have are, number one, training of physicians. So we are attacking this from the top down and the bottom up. So now we're training our medical students, our residents, and fellows who are in training. And then those clinicians graduate and they have some basic understanding of what point of care ultrasound is and how it can be used. But the average age of licensed physicians in the US is about 52. So most doctors who are out in practice did not ever get any of this training. So going from top down through CME courses, through programs we have through our VA system, through programs, other healthcare systems like Kaiser and others are putting together. We're trying to train doctors that are already in practice. So training is a big implementation gap that we have. But this pandemic highlights that, because if you haven't had training, you really in some ways are limited with what you can do at the bedside. The other one is equipment availability. So that's the other big barrier, which is becoming less and less of a barrier. And we've learned like the need to have equipment available, but also the benefits of having handheld portable ultrasound devices. They're small, they're easy to decontaminate, and they're more affordable. And so I think that's going to be another interesting lesson that we learn. But besides those things, so there's COVID specific things we've learned, what COVID looks like, and how it appears on ultrasound and how it evolves. But I think the big picture lessons we'll learn are we need more training, and now people are recognizing, we should invest in training. Second, we should invest in machines. And then maybe third, the lessons learned will be, there actually are benefits. There are important benefits that help the entire healthcare system. This isn't just like a fad or a little toy that's going to kind of come and go. This is actually something that we should look at seriously and make sort of standardized, across our systems or our practices.
All right, perfect. Well, I appreciate you walking me through that. Thank you so much.